Hello my friends, welcome back to my channel in the new video and this is after a long gap of Diwali vacations and I'm sure all of you must have had a wonderful Diwali festival. My sincere best wishes to all of you. This particular topic of sedation, analgesia and neuromuscular blockade in ICU is quite an extensive topic by itself and I've decided to divide it into 5 small videos, and this was a particular topic which I deliberated upon during the Uttar Pradesh Criticon 2025 which happened this month, earlier this month in the beautiful and the historic city of Gorakhpur. So let's start. Now, starting with this particular topic where the patients report the greatest stressors they encounter when they are admitted to ICU, especially due to pain, the sleep deprivation, and presence of the tubes and catheters in the mouth, nose, and every possible aperture. So, there is no doubt that these patients would have pain and, of course, anxiety and of course sleep deprivation thereupon. So as an intensivist, it is our duty to ensure how we can mitigate these problems, and we will discover this in my further slides. And as we know that sedation and adequate analgesia forms important quality indicators in critical ill patients, and this was a paper in critical care way back in 2006 which talked about the famous fast hugs bid, and there is that A and S which comes into play as far as these quality indicators are concerned. And of course, why we need sedation? Of course, to relieve the anxiety, to tolerate the tubes, especially the endotracheal tubes, the nasogastric tube. It controls oxygen demand because if the patient is awake and having a dysynchrony, then there would be a problem in the gas exchanges, as we know, and of course for the procedures like central lines, arterial lines, and so on and so forth. And these are the few basic questions which any critical care specialist needs to actually ask to yourselves and of course to the patient. Whether the patient is in pain or discomfort, are they afraid or anxious, or do you feel a short of breath when you ask the patient, or if they are thirsty, and whether there is any orientation of space and of course time and person. So these are the simple basic questions which we need to kind of throw to the patient. And this was Thomas Petty's submission way back in 1998 when he used to see the patients who were paralyzed, sedated, lying without motion, appearing to be dead, except for the monitors that they tell otherwise that yes, this patient has the heart rate of so and so, blood pressure or NIBP of so and so, saturation of so and so, and other parameters. So whether we were kind of having the suspended life or extending death during that time, and it was uh, the earlier era of between 90s and 2000s. So now of course we have had evolution of the thoughts, and the present day scenario is different than what they saw in 1990s and 2000s. So these are the few of the goals of the sedation, and as you could see, these are the predisposing and the causative factors like underlying medical conditions, acute medical or surgical illnesses, mechanical ventilation, invasive medical and nursing interventions, the medications, the infections, and of course the environment. And all of these culminate into something called as PAD, or that is pain, anxiety, and delirium, as you all will understand and agree to it. So, what are the interventions which we need to actually uh, kind of utilize in the form of either sedation or analgesia, antipsychotic medications, managing the predisposing factor, and the final target or the aim is to have a calm, alert, and a pain-free patient or an anxiety-free patient. He should not be a agitated one, neither he should be a completely unresponsive. We need to strike a balance, and this was a famous paper in Chest 2008. And before starting with the pharmacological means, I would like to start with the non pharmacological means. So, obviously, assurance of the patient, reassurance of the patient, even if it sounds a little lame to you, but these are the extreme important uh, factors or interventions as far as a critical care specialist is concerned. You need to communicate and interact with the patient. You need to see to it that whether the sleep hygiene is good. There is decrease in the noise reduction as far as the noise is concerned. The cognitive behavioral therapies, the relaxation techniques, the sleep cycles, correction of the sensory deficits if they are required. Of course, the physiotherapy, occupational therapies forms the mainstay of the back end of the any critically ill patient, minimizing the lines and the tubes as much as possible. And of course, last but not the least is restraint, but that we actually see to it that you know how can we avoid it as much as possible. But yes, when the time comes, we need to actually take a consent, explain the patient, explain the relatives, and then restrain the patient. So I think I will stop here, and it will just give you an introductory thought which will initiate the thought processes as to what are we going to discuss in my future videos as regards the sedation and analgesia, and of course the NMBs. So let's meet in the next video. Bye bye for now. Take care.